My presentation is on the cesarean section rate with elective inductions in spontaneous labor patients. My health question is, what is the effect on the cesarean section rate with the elective inductions versus spontaneous labor patients who are greater than 39 weeks gestation? I chose this topic because my passion is labor and delivery. I want what is best for my patients and ultimately a healthy mom and baby. I want to see if there's a significance related to elective inductions versus spontaneous labor patients. Do elective inductions lead to more C-sections than spontaneous deliveries? In my experience on the labor and delivery floor, I feel like I see more women end up in a C-section who do an elective induction. They are eager to get delivered, and sometimes their cervix is not favorable for induction, but still proceed with this process anyway and end up in a C-section. A C-section is not a bad thing necessarily if it is needed, but it is a major surgery, so looking at ways we can prevent it and have a healthy vaginal delivery would be ideal. Basically, how can our floor decrease the cesarean section rate, and what factors play into this increasing C-section rate? My null hypothesis is that there will be no effect on the cesarean section rate with elective inductions in spontaneous labor patients greater than 39 weeks gestation. My alternative hypothesis is that the cesarean section rate will differ between elective inductions and spontaneous labor patients greater than 39 weeks gestation. As you can see in my table, both articles performed independent t-tests to calculate if both topics were statistically significant. According to the studies of Levine, 2021, there was a statistically significant difference, meaning the p-value was less than 0.001. These results compared the C-section rate in induction and spontaneous labor. Lewis, 2022, conducted a study with a total of 1,528 women, where 158 were elective inductions and 1,370 were spontaneous labor patients. This study showed a p-value of 0.048 when comparing cesarean section rate. The results can help us decide if we should let labor happen naturally or induce. These articles were chosen due to my 7-year background in obstetrics. I have always wondered how induction affects the cesarean section rate and what we can do to decrease the rate. Both of the articles that I chose showed different statistical tests for a large amount of women. Levine concluded that their statistical findings were more favored towards spontaneous labor. Their study was a 7-year-long cohort in one hospital. The article states that these findings should be considered when deciding whether to electively induce or let labor happen naturally. Lewis stated that women have a higher BMI, are non-Hispanic, Black, or advanced maternal age have a higher chance of ending with a C-section birth. The article also states that providers should be informing patients with statistical data and considering risk factors of that specific woman when developing a plan for delivery. Lewis's article stresses the significance of higher BMI or advanced maternal age having a higher C-section rate. I believe that during prenatal visits, our provider needs to relay these statistics to the patient so that they have a better understanding that they are at risk. As healthcare providers, we can try and prevent a C-section by education, explaining why they need to maintain a healthy weight gain or loss in some circumstances. We also need to develop a plan of care that is specific to the patient and not just induce right at 39 weeks. We must sit down with the patient and look at their risk factors and educate them on the right path to take. These articles had different results on the effect of the cesarean section rate with induction of labor and spontaneous labor. Levine, Delfinito, Locher, and Ginsberg 2021 assessed the cesarean section rate after induction of labor and spontaneous labor at 39, 40, and 41 weeks. This test showed that cesarean section rate was greater than spontaneous labor in all 3 gestational ages. Lewis, Zoa, and Scorn did not see a greater cesarean section rate with induction of labor versus spontaneous labor. In my own 7 years of experience in obstetrics, I see patients that come in electively and be induced and end up in a cesarean section versus when they come in spontaneously. Now, I have not done a study to prove this on our floor, but these articles have differing statistical data. Both articles had legit statistical analysis and easy to read tables. Levine, DeFondo, Locher, and Ginsberg included a p-value for induction of labor versus spontaneous labor at 39, 40, and 41 weeks gestation, and also included a histogram table with percentages related to the 3 gestational ages and compared the percentages of induction of labor versus spontaneous labor. Lewis, Zoa, and Scorn had a smaller population of 1,528 null-parous women that they studied, and their results were not statistically significant. Levine, DeFondo, Locher, and Ginsberg had a population of 5,997 deliveries that were studied. They had to exclude 1,697 due to certain variables that did not pertain, such as elective cesarean section, placenta previa, and less than 39 weeks gestation. This study compared 2,017 women that were induced and 2,283 women who came in spontaneous labor. The numbers of women on each side were similar, giving this study a more balanced layout of research. In Lewis, Zoa, and Scorn, the smaller population size of women put a limitation on the study. Only 158 women in their study chose an elective induction, and 1,379 chose spontaneous labor. Each article ultimately focused on the cesarean section rate in spontaneous labor versus elective induction, and they did so with different variables involved and different population sizes. To compare results better, there would need to be multiple studies in multiple hospitals around the country to compare data and focus on the same specific variables and same population sizes. If I were to do more research on this topic, I would also research how specific nurse interventions can help prevent the C-section rate. For example, the use of more natural techniques like maneuvering of the patient, positioning, breathing techniques, water therapy such as water deliveries, and relaxation. All in all, this research was eye-opening, and I can't wait to do more research on this topic. Thank you for listening to my presentation.